a lot of the approaches that we've taken historically for ocular surface disease put the burden of how to implement, how to shop for products completely on the patient. The burden of getting the product, using it consistently over a long period of time, dealing with side effects, and dealing with the cost of those therapies, particularly the prescription therapies, entirely on the patient. But there's also a hidden burden that our offices share whenever we open our prescription pad, right? We've all experienced, and our staffs particularly experience, the fact that when we open our prescription pad, very excited to prescribe that hot new dry eye drug or therapy, we find out that those are denied. There's an appeals process. They require prior authorization. The patient's calling back because this medication is costing them $400 a month. But they really think they really think you want them to use it. So maybe they'll spend that money, but then they're kind of having buyer's remorse. There's a lot of burden on the staff in our office. We have two full-time employees that are dealing with prior authorizations, callbacks, medications, e-filing prescriptions, things of that sort. And I wish we were in a different place in our industry, but those two people are wonderful people, and they could be doing some really wonderful things in a more patient-facing direction, in a more productive way. But they're doing a really important but thankless task for us because of the way we are. And so this really makes it ripe for an interventional shift and an interventional mindset shift, where we have these therapies that we can provide for the patients, where when we know we've done the treatment, there's 100% compliance rate. The patients are more amenable to this because they're saying, well, if I have to do this particular therapy every day for the rest of my life versus coming in and doing a 10-minute treatment or a 15-minute treatment at the most, a couple times a year, I'm more willing to pay for that than to pay for this thing that I have to do every day, multiple times a day for the rest of my life. And that might not be the only thing that they have to do every day, multiple times a day for the rest of their life. To take that more historical, conventional approach. And so I really do like the interventional approach. E-Eye fits into that, IPL fits into that so squarely. And it was actually historically my first foray into interventional therapies for dry eye and ocular surface disease. I was, to be honest, a disbeliever. And I had Rolando Toyos, whose paper I read, his seminal paper describing the serendipitously discovered benefits of IPL in treating ocular rosacea and dry eye. And I actually invited to come visit Tampa, do some blind treatments where I was outside the room. He did the treatments, and then I'd walk in and try to figure out, after expressing the glands, which side of the patient he did. And I could tell every single time. And I was blown away at how immediate the effect was and how the patients responded to that. And so I became a true believer in the role that IPL can play. But to finish this sort of thought, these interventional approaches allow us to relieve the patient of the burden that they're carrying, improve compliance, improve patient satisfaction, and improve their compliance on these other therapies, the more conventional therapies that are adjuvants now to the interventional therapies that I think are primary. So that interventional approach, certainly a faster onset of action and timeline to relief, higher patient satisfaction, quality of life. They're willing to pay for that. That's certainly to their benefit and to our benefit. Again, a win-win. There's less burden of compliance and cost. And this is something that I want to double click on because it applies to what we just finished talking about in terms of hydro eye. When I tell patients any recommendation, I try to personalize it to them. And so that personalization is a two-way street. What I mean by that is I'm telling them, I think we should do this for your eyes because XYZ I'm seeing in your particular case. And I think this is best for you. But I also personalize it in the reverse direction. And I tell patients very truthfully, I have dry eyes too. I'm a LASIK patient from 25 years ago. I had thyroid cancer and I'm athyroid. So I have some risk factors for dry eye, just like you do. And I've been struggling to treat my own dry eye. And so a lot of these therapies I fail to do. And so therefore, I look for things that can get my body doing what it naturally is supposed to do. I'd much prefer natural approaches or homeopathic approaches than a pharmaceutical or chemical approach. And when I get done saying that, usually by a halfway point, I see patients kind of nodding their head and saying, yeah, I agree with that philosophy. I don't want to be fixed to a drug and take another prescription on top of the 20 that I'm already on. And I'd rather get my body doing what it naturally does. And so that really dovetails into a conversation for nutraceuticals like hydro eye, but also interventional therapies that get a patient's body doing what it's supposed to do without being tied to an endless, lifelong pharmaceutical approach. And so there are potential cost savings. This is something that's been published on in economic journals, medical economics journals, many times. So interventional therapies, far more cost savings to the healthcare industry and to patients versus topical therapies. It's certainly a more productive use of our time and our staff's time. And again, as I said earlier, better compliance with our conventional therapies. We're making revenue using our skills and our time versus opening that prescription pad. Big pharma makes the money, and then we carry the burden of callbacks, prior authorizations, et cetera, and staff time. And so I want to share with you sort of my trip down memory lane with IPL. I was first introduced to it by Rolando Toyos, who wrote that seminal paper back in 2002. And I kind of picked that up in 2008 when I joined the practice here in Tampa. At the time, we were using the Quadra Q4 by Dermamed. This was a pretty hot device. It was not cooled. So we'd actually put the device in a plastic bag and then put it in a bucket of ice water to keep it cool between patients. Because God forbid you're the 20th patient on my schedule on that Friday afternoon that I reserve for IPL and dry eye therapies. And it was a pretty hot device, and patients would literally jump off the chair and the table and scream because it felt like a hot poker, as many would say. I had one patient say that Guantanamo Bay has nothing on this device. So we moved on to the Luminous device, which became available. That was the M22 device. And that's the device that myself, Dr. Toyos, and Dr. Steve Dell out of Austin, Texas, wrote the seminal paper that led to FDA approval and clearance for the use of IPL for the dry eye indication and ocular rosacea. And so we used this device. It was also a pretty hot device, but at least it was water cooled. It was a little bit more comfortable than the Dermamed device, and we certainly saw good results with it. Somewhere around the end or midpoint of 2020, I was offered them to exchange out, Luminous offered to trade out my M22 device and place an Optima device, their upgraded device that changed the way the pulses were delivered into multiple pulses instead of 3 big bursts. And it was certainly a lot more comfortable than the M22 device that preceded it. But after about 4 months of using this, the patients were telling me, I don't think this device works as well as your other device. Even though this is a lot more comfortable, I kind of like the results that I was seeing with the other device. And so I listen to my patients when they say those things. I asked Luminous to give me back my M22. And so they took back the Optima and they replaced my M22. But it just turns out at the same time I heard about SWIN from colleagues in the industry. SWIN is a French-based company, based in France, and their E-Eye device and their tear check diagnostic device. And so I started using it, and I saw the results were as good as, if not better than, the M22, in my opinion, and in my clinical observations. And patients were telling me, boy, this is really comfortable. I feel it. I know it's worked. But patients were saying, this is more comfortable and it's working. That's all I needed to hear. And so I've been sticking to the E-Eye device since 2022. In total, I had to look back in preparation for this presentation. I've done 13,600 IPL treatments on countless numbers of patients. Some of my patients have now had their like 15th or 16th maintenance therapy, and they come in on a regular basis. What's wonderful is, regardless of what all the data says, and I'm about to share some data with you, because again, we're data-driven doctors and clinicians, but regardless of what the data tells us, when patients tell us with their phone calls and with their feet, and they vote with their feet, and they're coming in ahead of a scheduled follow-up treatment, they're voluntarily saying, hey, doc, can you get me in for a treatment? I think I need one. And they're willing to pay out of pocket what we charge, and they're willing to come in earlier than a scheduled treatment. It tells me everything I need to know about efficacy, the price we're charging, and the perceived value that they're getting for it. And so they're coming in oftentimes a little bit sooner than a scheduled appointment for a treatment with the E-Eye device. And that's great. I'm like more than happy to accommodate anyone's schedule and get them in for what amounts to about a 3 to 4 minute treatment. We all see patients like this that have the typical dermatologic rosacea, but we have to identify the ocular rosacea, which can be a little bit more subtle with lid margin telangiectasias and MGD combined. This was the paper that we published that showed these statistically significant differences in lid edema, facial telangiectasias, lid vascularity, MGD score, OSDI score, so signs and symptoms, as well as meibomian secretion quality and tear breakup. This was a randomized control study with blinded observers, so masked observers. So I think a pretty powerfully designed study with three sites, myself included. So how does IPL work and what makes E-Eye different? E-Eye utilizes IRPL. So there's a little bit of alphabet soup here. This has an indirect effect on the parasympathetic nerve system. We know that the parasympathetic system is what gets the meibomian glands pumping. This is relayed through a release of certain neurotransmitters because of this temperature gradient that's delivered with the light pulse. And so multiple mechanisms of action, but there's also a photocoagulative or photothrombotic effect on those telangiectatic vessels. There's also an antiparasitic and antibacterial benefit. So it's operating on a lot of different levels. And of course, patients love the side effect of the collagen synthesis and rejuvenation treatment and benefits. So we make it a point to offer, I'm treating around your eyes, but for an added cost, patients can have their whole face done as well. And sometimes for particularly the female patients that are on their first treatment, I'll ask them politely, hey, while I'm here, do you mind if I treat some of these other spots on your face? And they're saying, oh, wow, really? Would you do that for me? And I'd say, yeah, I can do it. I'm here already. There is a cost associated with that the next time if you want to keep doing it, but I'm happy to do it. I'm already here. And they see that value add. And so we're always looking for those kinds of value adds. The E-Eye device in particular has been well studied, and so it is scientifically backed. A lot of studies done outside the US, and we are getting ready to initiate a clinical trial that is designed to be identical to the previous trial with the Luminous device with the SWIN, so we can show certainly clinical efficacy and non-inferiority and get that same indication. So this was launched here in the United States in 2016, very high user satisfaction rate, but it utilizes this IRPL. I want to take a step back and kind of share with you what IPL really is. And so intense pulse light usually is described this way. There's a lot of IPL devices out there in the market that have very poorly regulated fluence or delivery of that light energy. So sometimes you'll see these very irregular spikes of energy that within each pulse is very poorly regulated as well. And so different durations, different amounts of fluence with each pulse delivery. Um, IPL from Luminous, the M22 devices, its claim to fame was we have very finitely controlled energy delivery. The problem that I saw with that in terms of patient comfort and how it translated to patient comfort is that while it was efficacious, these three big wallops of energy were very much felt by patients. And so it made for a very hot, uncomfortable treatment, particularly for those fair patients with low Fitzgerald skin type scores, high fluences, high power is going to be used. They would jump off the table and not be so amenable to repeated treatments and going through the entire course of therapy. So IRPL is different, eSWIN is different, and the E-Eye device is different. It's regulated, controlled delivery of fluence or energy, but the breakdown of how these pulses are done is it's 8 pulses with a very carefully programmed pulse duration and fluence. And so you've got variable but controlled pulses of varying durations, 8 of them. So the total amount of fluence is pretty big, about 13 millijoules for the average patient per pulse. But with the 8 pulses, the patients hardly feel it. So they don't even flinch really. They're more reacting the first time we do it to the flash of light, but not the sensation of any discomfort on their skin surface. And so this is how we get the same benefit with far greater comfort. It is fast, it's efficient. This takes literally about 3.5 minutes for me to do. With the other devices, because it had a really small patient interface head that was about 2 square centimeters, it certainly allowed us to get into different nooks and crannies, but a typical treatment would require 3 passes to get to clinical efficacy. That's the protocol we used in the study. That would amount to about 80 to 90 shots per treatment for a total treatment both sides. With the E-Eye device, because of the way this is pulsed, it's a larger head, so a greater surface area covered. It allows us to ergonomically maneuver it right to the eyelid margin, and it's 5 shots per side. And I'll demonstrate this to you. My protocol is perhaps a little bit different than other folks, but we lay the first pulse here kind of parallel to the nose. I wiggle up right up to the sticker that we've placed over their eye. I place that sticker very close to the eyelid margin. So when I'm placing it, I have the patient look up. I catch the adhesive on their lower lashes, and then I fold it up and I have them close their eye as I lay it down. That way I know that that lower edge of the sticker is placed right at their lash line. And when I place the device with a little bit of cool gel, ultrasound gel, I slide the edge of the light delivery device right up to the edge of the sticker and I push up a little bit. I slide it up. So I know I'm right at the lash line and I'm covering the space around the meibomian glands. And so the first shot is here, second shot slightly overlaps, and I kind of do 3 shots vertically. And then I feather it out and I go horizontal with 2 shots. That's the treatment for that side in total. And it takes literally 3.5 minutes. And the patients don't really react. They go about their normal day. My protocol that I've developed in practice based on our previous studies, we try to do these treatments about 2 to 4 weeks apart. We noticed that when we started extending this initial treatment series beyond 6 weeks, there was a little bit of a decline in the effect. And so when we're doing our initial 4 sessions, 4 treatments, we try to space these out about 2 to 4 weeks apart. Very high patient satisfaction rate, very high capture rate, so very low rate of recidivism of patients saying, hey, I don't think this worked. I don't want to continue paying for it. We've also noticed that with historically other IPL devices, patients would have to get to their 3rd or 4th treatment before they started noticing a difference. Whereas with E-Eye, they're noticing a difference pretty much right at 1st or 2nd treatment. So there's a lot less cheerleading on our part that has to happen. It's oftentimes useful to show patients what normal is and what they look like. And that sort of gets the conversation going. But I wanted to just highlight a diagnostic device that eSWIN manufactures called the Tear Check that provides a lot of different diagnostic modalities or metrics that are useful to starting the conversation and having some objective measures of ocular surface, blink rate, tear film stability, et cetera. I don't use all of these different modalities. I find it a little bit more efficient for me to just explain it in words to patients and analogies. But I think this is a wonderful device because it provides all 9 of these different metrics to get a conversation going, explain it to the patient, and give you a prop to get a conversation going in about 2 minutes. And so a very, very nice system to perhaps avail yourself of. My protocol for IPL, as I said, is typically a four treatment course, each about 2 to 4 weeks apart. They're continuing their home regimen. Remember, first line therapy is Hydro-Eye, nutraceutical, tears, Mibo, their immunomodulatory drop of choice. All of those are first line. We've done the Lacrophil. They're good. We're now doing the interventional treatment. After the treatment, they're on loteprednol for 5 days, and then they come back for their second, third, and fourth treatment. What we've integrated into our discussion is the fact that IPL or E-Eye is going to help the reason the glands get clogged in the first place, but we got to get the glands unclogged. And Tear Care, a thermal device, allows us to really efficiently get the patient's glands unclogged. And then the IPL treats the reason the glands are clogged in the first place. So it's a powerful 1-2 punch. And when we combine those as inductive therapy on the first visit, so first Tear Care and their first IPL back to back in the same visit, it allows the patients to leave their first visit already feeling like, oh yeah, I can feel my eyes are already better. Now that might be a short-lived benefit until they get their next treatment, and you get longer and longer duration of that benefit by the time you get to the fourth treatment. And then we switch to a treat and extend sort of philosophy, where after their series is done, we do their first maintenance therapy at about 4 to 6 months. If they're doing well, we extend that on and on until most patients are at a point where they're having a single yearly IPL treatment and a single yearly Tear Care treatment, alternating back and forth about 6 months apart. And that's where most patients end up very, very, very happy. I'm careful to empower my patients, and I use the time that I'm expressing their glands after the treatment. I do it before and after to tell the patients you're in charge of the cadence. So if you feel like you need a treatment sooner than what we've scheduled, call our office, we move you up. But if you feel like you're doing great as you lead into a get closer to your next scheduled treatment, call the office and feel free to push it back a month. That puts me on their side. It aligns my interests and their interests, and they don't feel like I'm trying to push or sell them on treatments. They feel like, oh, okay, he's empowering me to push it out if I'm doing great, and he's not just trying to sell me on a treatment. I can tell you that patients frequently call to have a treatment sooner. I've had very few patients call to push it back. Most of the time, they just come in for their scheduled treatment and they're saying, I was doing great, but I figured I may as well just keep the appointment and have my next treatment. And that's wonderful to see. It tells me, again, everything I need to know about cost, value, and efficacy right from the patient's own mouth. And so I want to highlight some cool things I see about E-Eye particularly. It's air-cooled. It's a small device. It's portable. We've got 5 different office locations about Tampa Bay. And so this device kind of fits into a suitcase. So it does make it possible to provide this treatment in multiple locations. And again, this is GPO. So we're talking to a pretty advanced group of people. We want to look at what's the ROI, right? And so this device allows us to enter the arena of IPL, provide this great service for patients, but at a much, much lower startup cost than other IPLs that are out there, like the Luminous device. And so we have a faster ROI. We had a 2-month ROI because I was already doing a pretty good volume. But even on pretty low volume, you're going to have about a 6-month ROI to break even. And then from there, the costs over the lifetime of this device are very, very minimal because it's a simple device. There aren't a whole lot of moving parts. And so the maintenance costs are kind of included. And perhaps I'll let JC chime in here in terms of their business model and pricing model. But there's a lot of included costs here, no surprises. Whereas with other IPL devices, I think there are a lot of add-ons that can get kind of pricey. And so this allows us to enter the arena and get into IPL and provide this for our patients really, really quickly and efficiently and cost effectively. So to summarize, and then we'll open up for some questions perhaps again. Patients look to us for recommendations. They're looking to us for results, not more of the same. And so we have to get them to say no to more of the same and make them more amenable to perhaps other treatment options that they haven't tried. Because after all, in life, as in ophthalmology, if you want something you've never had, you got to do something you've never done before. And that's true for patients. If they want a result, an outcome they've never had, they've got to do some things they haven't tried. And for our practices, that's true too. If you want to grow your practice, you want to see patients and have more patients come into the office and build your cataract refractive side, you've got to build the ocular surface size too. And so if you want to grow your practices in ways that you haven't been able to do before, you've got to do some things that you've never tried before. And these two things and platform technologies have been useful for me. Natural and interventional approaches certainly are appealing to patients. I think this resonates to patients. And Hydro-Eye and IPL, certainly first-line therapies for dry eye, and definitely integrated into my pre-refractive and pre-cataract thinking for ocular surface optimization. I can't believe I did it in an hour and 5 minutes, Cynthia, but somehow I did. I talked passionately about two things that I love and that really do work. I'd love to get some questions if there are any.
There are questions actually, Neel. And like you said, you could talk about these two products for a day
I could.
because I know how passionate you are about them and how helpful it is really to patients.
Yeah.
They are for the first time feeling the benefits, the decrease in the symptoms in their eyes is such a relief for them. You know, dry eye is a chronic pain disorder. And to be able to provide pain relief for these patients who have been suffering sometimes for years is such a rewarding feeling. So your protocol is very similar to what mine used to be, but we do have some questions. So because of time, I'm just only going to limit it to two. Do you use the E-Eye for the treatment of chalazion?
I do. And so there is a pretty cool protocol for that. And all it requires is some kind of masking device, which is basically a hole punch card that has different sized holes. So you can mask the patient interface and just focus the IPL on the chalazion itself externally. And so I usually do about 3 shots based on the patient's Fitzgerald skin type. And we usually do 2 treatments. Again, this is not a replacement for conventional therapy. So I'm having the patient do frequent hot compresses. I've got them on, Tobra dexamethasone ointment. And what we find is that the E-Eye helps speed up the resolution of a chalazion, and it makes it a lot more comfortable. It tends to help them drain on their own without some kind of traumatic curettage that then in turn causes the neighboring glands to create chalazion too. And so this is a minimally invasive interventional therapy for chalazion. During COVID, we used to see a lot of patients with chalazion. I don't know why. I think it was because of the masks. And we're kind of breathing into our own eyes and spending a lot more time on the computer for sure. And so we used to see a lot of this. And so integrating this into our chalazion treatment was really, really useful. On occasion, I'll combine this E-Eye device and treating it with an injection of Kenalog, intralesional Kenalog, and 5-FU. And that combination is wickedly fast. The patients usually see resolution within about 2 days.
That's great. I'm glad you shared that, because a lot of patients obviously feel disfigured with chalasia, and especially if there's an upcoming event, it's the wedding of their, family member, and they need ASAP treatment. I've done that too, and it works great. We have a question. Do you express the glands after each IRPL treatment? And that will be our final question, Neel,
Yes.
due to the time constraint.
Sure. So with the first IPL, again, I combine this with some kind of thermal expression device, and my preference is with TearCare because it just feels so good and it's very ergonomic for patients. So we use TearCare, but because they're getting the TearCare just prior to their first IPL, I don't do a cold expression right before their first IPL, but I do it after every single one. And then for their second, third, and fourth IPLs of the series and any maintenance therapy, I'm expressing the glands before a cold expression and then immediately after the treatment is done. And that cold expression allows me to kind of narrate to the patient, this is how we're doing now. And then it allows me to narrate to the patient after the treatment, immediately after the treatment, okay, it looks like we've got some good stuff coming out. We've gotten this gland unclogged. Now the secretions look much clearer. They're not looking like toothpaste and sludge. Now they're coming out clear like olive oil. And to kind of give the patient that positive feedback. So to answer the question, yes, I express after every single treatment and before every single treatment except that very first one, but only because I'm doing a thermal expression essentially right before that first treatment.
Got it.
And I think that
Excellent
expression.
explanation. Yeah. Thank you, Neel. You were wonderful.
Absolutely.